All right. Thank you so much for that warm introduction and for the opportunity. And I believe that I'm going first with a slide presentation to talk about the updated guidance around opioids and cannabis for chronic pain. So I'm going to share my screen and I'll try to move through this in a reasonable pace, and we have lots of time for discussion after as well. So to begin, I do have some disclosures. I'm the director of the National Pain Center at McMaster and the associate director for the Michael G. DeGroote Center for Medicinal Cannabis Research. I do hold government grants, but I have no for-profit relationships to declare. So to begin, we did publish the guideline in 2017, providing information and evidence on the use of opioids for chronic non-cancer pain. And we
Jason,
undertook, yes.
sorry, I'm just going to interrupt you quickly. You're in presenter, you're not in presenter view. So
Oh, I'm sorry. I wonder what's happened.
even though we tested it,
Yeah. All
seeing your
right.
next slide. So
Let's try that one more time. Thank you for telling me.
you're most welcome.
Now, how's that?
That is perfect. Thank
Oh,
you.
good. Thank you. We did undertake an update of the guideline quite recently, and we began by assembling a panel of 20 individuals, and I've listed them here for you. We have 4 patient partners. Some of those names may be familiar to some of you. We had 11 clinical experts, and we had individuals from family medicine, from behavioral medicine, addiction medicine, clinical pharmacology, rheumatology, public health. We had a physical therapist, a psychologist, a gastroenterologist, and then we had methodologists, several of which are also frontline clinicians. And the condition of being a panel member was that you could not have any significant financial or intellectual conflict of interest. We use something called the GRADE approach to make our recommendations for this guideline. Now, with the GRADE approach, you can make a strong recommendation or a conditional recommendation. The recommendation can be for or it can be against. We can make a strong recommendation when there's a clear imbalance between benefits and harms. If there's much greater benefits than harms, it would be a strong recommendation in favor. If there were much more harms than benefits, it would be a strong recommendation against. We do require moderate or high certainty in the evidence behind those benefits and harms. And we have to perceive that if given that evidence, essentially all patients would make the same decision. We make a conditional recommendation if there is a close balance between benefits and harms. In this case, it's a much more preference-sensitive decision. Some patients might place a higher value on the potential for benefit. Others might place a higher value on the potential of harm, but because they're closely aligned, the decisions are likely to be different. We might make a conditional recommendation where we have lower certainty evidence. So we're not sure if new studies are going to change the evidence for benefits and harms. And we make conditional recommendations when we perceive that if given this evidence, not all patients will make the same choice. We will have appreciable numbers that would choose to pursue the intervention, but also appreciable numbers that would not. And we don't know the answer until we speak to the individual patient and help them to make a decision that is consistent with their values and preferences. Now, we have to understand values and preferences in order to interpret the evidence. And so we undertake a formal systematic review of the literature to see what we can understand from studies that have been done on patients' values and preferences. And we also conduct our own focus group interviews with people with lived and living experience. And we take all this evidence and we use it to formulate a values and preference statement that the panel then uses to formulate the recommendations, because evidence alone is not enough. So what is the values and preference statement that we arrived at after our systematic review and our focus group? We determined that for people living with chronic non-cancer pain receiving opioid therapy, pain relief was their most important consideration. It's not the only consideration. They're interested in improving sleep, improving function, but reducing pain is the primary concern. We learned that when patients experience side effects such as severe nausea, vomiting, or constipation as a result of opioid use, those adverse effects are almost as important as pain relief, and therefore might be more important than small degrees of pain relief. And we saw this from the randomized control trials as well. If a patient dropped out of the study, it was often because they were experiencing one of these side effects. When we looked at other opioid-related adverse events, such as sleep disturbance, personality changes, dizziness, mental fog, they were less important, but were not irrelevant. So they also deserve consideration when making clinical recommendations on this topic. When considering rare but serious adverse events, such as an opioid use disorder or a fatal or non-fatal overdose, we did view societal values and preferences as very important. We are aware that this is an important public health concern. So we did place a high value on avoiding these events, even though they were rare. And in particular, when we conducted our focus group interviews with patients, it revealed that individuals using long-term opioid therapy for chronic pain were quite concerned about withdrawal symptoms that might result from efforts to wean or discontinue their opioid use. So for those using high doses of opioids and who consent to tapering, so again, this is talking about voluntary consent, not involuntary tapering. So for those that consent to a trial of tapering, we continue to place a high value on the societal considerations of minimizing risk of rare adverse events, but we also placed a high value on avoiding severe suffering, increased pain, and functional limitations that can accompany efforts to taper opioids. So that was the information that we used to interpret the evidence. So our first question really was, if an individual presents for care with chronic non-cancer pain, should they be offered a trial of opioids as first-line therapy as opposed to treatment of non-opioid sorts? And again, we could make a strong recommendation either against or in favor of opioids, or we could make a conditional recommendation. And again, conditional recommendations are candidates for shared decision-making because it's conditional on patients' values and preferences. So to give you a sense of the kind of evidence we found, this is evidence from randomized controlled trials. It is all high to moderate quality evidence, so we're fairly confident here, quite confident. We found evidence for modest improvement in pain relief. And in particular, when we look at the likelihood of achieving at least the smallest amount of pain that patients consider to be important, which is about 1.5 points on a 10-point scale, you get about 10% more patients that achieve that important benefit versus patients that are prescribed a placebo. Said another way, you have to treat 10 patients with opioids for chronic pain for one to achieve an important reduction in pain symptoms versus placebo. So it is a significant effect, but it is a modest effect. It will work for a minority, but not the majority. The evidence for physical function, we also found a significant benefit with opioids, but it was a little smaller. Here, the additional number of individuals achieving important benefit over those receiving placebo was 8%. So we call that the risk difference. And that means when we translate it into the number needed to treat, you have to treat 12 patients for one to achieve important functional improvement. For sleep, a significant benefit, but a little smaller still. Here, the number needed to treat was 17. When we looked at other outcomes, such as emotional functioning, role functioning, or social functioning, we found no important difference versus patients that received opioids versus those that received placebo. And all effects were independent of dose or type of chronic pain. Well, what about harms? Well, we found high-quality evidence that there is a risk of experiencing a fatal overdose, and it is dose-dependent. At low doses, that risk is about 1 in 1,000. When you get up to higher doses, that risk doubles. When I say higher doses, I mean more than 100 milligrams morphine equivalent. So it is a significant risk. It is a small chance of occurring, but obviously it's a devastating outcome when it does. Non-fatal overdose, again, could occur. We found the risk was about 1 in 500. Gastrointestinal events, a little bit higher. Here, the risk difference was almost 8%. That means the number needed to harm is 13. For every 13 patients treated with opioids, one will experience problematic gastrointestinal harms. Pruritus or itchy skin, also significant, but not that common. Again, number needed to harm is 16. Dry mouth, dizziness, drowsiness, statistically significant, but again, they're small likelihood again. Number needed to treat between 33 and 67. We found moderate quality evidence that there is about a 5% chance of developing an opioid use disorder, an addiction to opioids during the course of treatment, and that about 5% of prescribed medication is at risk for diversion. That means someone will end up using it that was not originally prescribed to use it. So what about alternatives? Well, when we looked at randomized controlled trials that looked at opioids versus other active agents, things such as non-steroidal anti-inflammatory drugs, tricyclic antidepressants, nabilone, which is a synthetic cannabinoid, or anticonvulsants, it seemed to show equivalent results. So we have a number of alternatives that do seem to show similar benefits to opioids. Again, they're not going to work for everyone, but they have a similar likelihood of working. And they do not have some of the side effects associated with opioids, in particular when we look at things like a fatal or non-fatal overdose. So given that information, when we're considering whether or not opioids should be first-line care for chronic pain, our panel made a strong recommendation that opioids are not first-line therapy. Individuals that are coming in for treatment of chronic pain should be optimized on non-opioid alternatives first, simply because they're likely to find a similar degree of benefit. Not everyone is going to find relief, but there is a lower risk of catastrophic harm in most cases. Recommendation number 2, we looked at individuals who have tried non-opioid therapy, but they continue to experience problematic pain. And because we did find evidence for a benefit, although the benefit is only for a minority of patients, the panel made a strong recommendation to discuss a trial of opioids for, again, individuals with chronic non-cancer pain who had been optimized on non-opioid therapy, still were having problematic pain. But again, we had some carve-outs in this recommendation. You see that we excluded individuals with a current or past substance use disorder, without another current psychiatric disorder, and without a history of opioid overdose. We carved out these subgroups because they have a different amount of risk when they are prescribed opioids. They have a higher risk of either developing an opioid use disorder or of overdosing. So this recommendation excludes those particular subgroups, but we do deal with them in separate recommendations. And again, a strong recommendation to have a discussion is entirely consistent with an outcome that many patients would decide they were not interested. So it doesn't mean that they will undertake a trial of opioids. It simply means they should be given the option to consider, after looking at the evidence, if it's something they would like to pursue. So again, looking at those carve-out groups, what about individuals that have a history of opioid overdose? Well, we know from the evidence synthesis that we did that their risk of experiencing a fatal or non-fatal overdose goes up 6 times. So even though the baseline risk is fairly low, the panel felt that that was too much of an increase in this very important harm, that we should make a strong recommendation against offering individuals that had a history of an opioid overdose a trial of opioids. And again, it's simply because of the elevation in the risk of potential serious harm. Similar recommendation for individuals that have an active alcohol use disorder. Once again, here, the increase in suffering a fatal or non-fatal overdose went up 5 times in this particular subgroup of patients. So again, this is an active alcohol use disorder. It does not pertain to individuals that had a prior alcohol use disorder. Now, we did cover that in our 5th recommendation. So again, we looked at individuals with a history of any substance use disorder who have persystematic pain despite optimization of non-opioid therapy. And in this case, the risk of additional harms did go up, but it wasn't as high. It wasn't as high as the other two categories of patients that I showed you. And so the panel felt that there would be some patients that even after being made aware of the potential for harms would still want to pursue a trial of opioids. So in this case, the panel made a conditional recommendation against a trial of opioids. But a conditional recommendation means you talk to the patient. You say, this is what we know about your potential for benefits. You do have an elevated risk for harms. Here is what we know about that. What would you like to do? And we perceive that the majority of patients would probably be disinclined, but an appreciable minority would still be interested in a trial of opioids. So again, conditional recommendation means talk to the patient, help them to make a decision that they're comfortable with. Similarly, for individuals with a history of mental illness or an active mental illness, who again, they've been optimized on non-opioid therapy, they haven't found sufficient relief, they're asking, what about a trial of opioids, or you're considering a trial of opioids. It's a conditional recommendation. There is an elevated risk of developing an opioid use disorder. There is an elevated risk of an overdose, but it's not so high that we felt that all patients would be disinclined to try. Some may place a higher value on the possibility of important pain relief, even though it's about 1 in 10, than they will on the increased risk of harms. So conditional recommendation means provide the individual the information, help them to make a decision that they're comfortable with. What about dose limits when someone is being initiated on a trial of opioid therapy? Well, when we look at all the randomized controlled trials out there, the typical dose of opioids is about 46.5 morphine equivalent per day. When you look at the interquartile range, it goes as low as 30 milligrams per day up to 83. And when we look at the evidence from observational data, we do see that as you increase the risk, you increase the dose of opioids, you do increase the risk of experiencing an overdose. The first time we did the guideline in 2017, we had very thin literature. We only had a couple of thresholds to use, 20, 50, 100, and 200. That was it. And so we were constrained in our recommendations with considering that. This time around, we had more evidence. We had sufficient evidence that we could build a dose response curve for harm. And I put it up here. So you can see here, these are the odds of experiencing an overdose. And this is the sort of daily dose of opioids, morphine equivalent. And you can see that it sort of slowly starts to go up and then it goes up quite sharply. Because the panel had already made decisions about the elevation in risk that would cause them to make a strong recommendation against and a conditional recommendation against, we were able to then use those risks to determine what dose that corresponded to. So to have internal consistency in the guideline, that's what the panel asked, right? So the panel said, we decided that, for example, if someone had an active mental illness, that increased their risk of fatal overdose 2.5 times. If we look at the dose that increases risk by increases the risk by 2.5 times, what is that? And we were able to determine on the curve that it corresponds to 80 milligrams morphine equivalent. And then the panel said, well, we decided for a strong recommendation against that if the risk went up 5-fold, that's where we would make the recommendation. What dose on this curve corresponds to a 5-fold increase in the risk of overdose? That turned out to be 150 milligrams morphine equivalent. So in order to be internally consistent with the other recommendations, this was our combined statement. In people living with chronic non-cancer pain, undergoing a trial of opioids, the panel suggests avoiding doses higher than 80 milligrams morphine equivalent per day. And again, that's conditional, right? So again, that means it's a discussion with the patient if they're getting partial relief and they maybe want to try to go a little higher. But the panel said that probably seldom, if ever, exceed doses higher than 150 milligrams morphine equivalent daily, because we're getting up to that elevation in risk that they felt was too high to justify the modest potential benefits. So again, there will be some individuals who would accept the increased risk of harms associated with a dose higher than 80 milligrams morphine equivalent. However, we felt it would be almost very rarely be the case to go higher than 150. What about individuals that are prescribed opioids for chronic pain, but they are having problematic side effects? We found low certainty evidence that if patients are rotated to an alternate opioid, that may provide better results. And so again, the panel made a conditional recommendation. Some patients may say, oh, you know what, I've tried it, it's not working well for me, I don't want to keep going. Others will say, all right, there's at least a chance that a different formulation might prove more helpful. I think I would like to try it. Conditional recommendation mandates a discussion with the patient. Now, our 10th recommendation gets into a very important topic. What about individuals that are already prescribed opioids for chronic non-cancer pain, often at fairly high doses? Well, in this case, the panel, in recognition that there are an increase in harms associated with higher doses, made a strong recommendation to initiate a discussion about offering a trial of opioid tapering to the lowest effective dose, potentially including discontinuation, and if the offer is declined by the patient, to repeat that offer, to re-engage in that discussion every 6 to 12 months. So again, it's a recommendation for a discussion. So we really wanted to hammer home the point here that the final decision will rest with the patient. The onus on the prescriber should be to at least offer an offer of a tapering if they are interested. Why? Well, we've got emerging evidence from randomized trials that shows that voluntary supported tapering can often be successful. We have a couple of large randomized controlled trials that just came out. There's another one that's been presented at conferences called the Empower trial that will be out in press soon. And again, it can be successful without increasing pain or other withdrawal symptoms. However, we also have lots of evidence from observational studies that involuntary opioid tapering is associated with increased harms, including opioid overdose. So we're talking about voluntary consensual tapering, and we have another associated remark with this recommendation, which says some patients who agree to opioid tapering may experience a substantial increase in pain or decrease in function after a small dose reduction, and tapering may be paused or potentially abandoned in such patients. The decision to attempt it is up to the patient. If they say no, that's fine. If they say yes, there's still a safeguard in place if they start to not do well at some point in that tapering process. We have one good practice statement with the updated guideline. Here it is. Patients with chronic non-cancer pain prescribed opioids should not be engaged in forced or involuntary tapering. We have a great deal of evidence that that is not a good idea. Finally, for people living with chronic non-cancer pain who are engaged in voluntary opioid tapering and experiencing challenges, we suggest engagement in multidisciplinary support. It's a conditional recommendation because the evidence is low certainty, but we have data from observational studies showing that multidisciplinary support can be helpful in such circumstances. Now, that is a very quick overview of the updated opioid guideline, and I'm going to give you an update on our cannabis guideline as well. As indicated in this editorial in the Journal of the American Medical Association, there is increased pressure to move away from opioids when possible. Cannabis is increasingly available, but the question is, what evidence do we have that it can be helpful? We once again began with a panel. We had, in this case, 5 people with lived experience, 3 methodologists. We had 15 experts. And again, they represented a wide range of fields here, anything from rheumatology to family medicine, pharmacology, respiratory specialists. We actually had a palliative care physician involved in this as well. So a wide range of skill sets to weigh in. As we did with the opioid guideline, we undertook formal processes to inform our values and preference statement. We did a systematic review of the literature. We also conducted a qualitative study with 52 individuals with lived and living experience. This is what we learned. Again, this is almost a copy and paste from the opioid guideline, but people living with chronic pain place high value on the possibility of small but important pain relief. And they are often willing to accept the possibility of the modest harms we know are associated with cannabis for medical purposes. We found that people living with chronic pain typically, not always, but typically place a higher value on the possibility of increased pulmonary harms, lung harms with inhaled versus non-inhaled cannabis, and a lower value on the possibility of improved pain relief with inhaled versus non-inhaled formulations. We found that patients living with chronic pain may view cannabis for medical purposes as safer than prescription medicines. Specifically, opioids came up a lot. And values and preferences towards cannabis for chronic pain are likely to vary amongst patients based on their sociocultural context and their prior experience. So that's what we learned. In terms of evidence, again, these are from evidence syntheses of randomized controlled trials. This is all high to moderate certainty evidence. There is evidence that compared to placebo, therapeutic cannabis can result in important pain relief. The risk difference versus placebo is 10% more. So 10% more patients that receive cannabis will achieve important pain relief. Once again, that means you've got to treat about 10 patients for one to get important relief. Physical function, it's less. Here the risk difference is 4%. So you've got to treat 25 patients for one to get that important functional improvement. Sleep, it's a number needed to treat of 17. So these are statistically significant effects. They are modest. It will not provide important benefits for most patients, but it will for a minority. We found no important difference when people were using medical cannabis for chronic pain versus placebo in either emotional functioning, role functioning, or social functioning. What about harms? Well, we had moderate quality evidence that there was a small risk of cognitive impairment. A risk difference of 2% versus placebo means you have to treat 50 patients for one to experience this harm more so than placebo. Vomiting, a little bit more common, but still fairly infrequent. Number needed to harm of 33. Drowsiness, number needed to harm of 25. Dizziness, we found a subgroup effect. For people that are being managed with cannabis for less than 3 months, the risk difference is 8%, means the number needed to harm is 13. With longer term use, an episode of dizziness becomes at least, much more common. Here, the number needed to harm was only 3. Impaired attention could happen, but again, fairly infrequent. Number needed to harm of 33. Diarrhea, number needed to harm 25. Nausea, number needed to harm of 20. Memory impairment, number needed to harm 39. So again, you can experience these harms. They will not affect most people that use cannabis for therapeutic purposes. What about the more serious harms, right? Things like suicide, suicidal attempt, mania, hallucinations, paranoia, anxiety, falls or motor vehicle accidents. We have lots of evidence from studies of recreational cannabis that some of these events can be increased. It turns out when we look at therapeutic use of cannabis, which does tend to be different than recreational use, we have low quality evidence that it may not increase the risk of any of these harms. Again, low quality evidence, we're not sure, but we don't see a signal. And we have very low quality evidence about things like dependence or suicidal thoughts. So that's what we know about benefits and harms. And so again, when we asked our panel, what do you think here? They once again decided that cannabis is not at the point where it has enough benefits that it should be considered first-line therapy, but for individuals living with chronic cancer, or in this case, non-cancer pain, when troubling pain persists despite optimization of standard pharmacological and non-pharmacologic care, the panel suggests offering a trial of cannabis for medical purposes. It's a conditional recommendation, meaning we think patients should be given the evidence for benefits and harms and encouraged to make a decision consistent with their values and preferences. Right? There's the possibility of benefit, although small. There's also the possibility of harm. It depends what patients place higher value on. Now, when we talk about initiating a trial of therapeutic cannabis, we then have to make a decision in what type of formulation. And because of the information we got on values and preferences, because of reviews that we did looking at non-inhaled and inhaled formulations that tended to show similar benefits, but there is the increased risk of pulmonary harms when you're inhaling, the panel made a conditional recommendation that if a patient has decided to engage in a trial of therapeutic cannabis for their chronic pain, that they be offered a non-inhaled formulation over an inhaled. Now, a conditional means they may choose to go against that. They may choose, because of their prior experience, that they would like to go with an inhaled formulation. And in that case, we suggested that vaporizing would be a preferable option to an inhaled product versus smoking. And it's simply because of the decreased risk of lung harm. So again, it appears as if the inhaled and non-inhaled is going to be similarly effective. We do know that the inhaled will sort of have a faster effect, but it'll also attenuate quicker. But because of the elevation in pulmonary harms, we felt that most patients would like to try a non-inhaled formulation first. Now, what about using cannabis to help taper off of opioids? Well, we looked at a number of observational studies and we found that there was evidence to suggest that this could be occurring. At least from the 6 studies we had, we found very low certainty evidence that when patients were provided access to therapeutic cannabis, they were able to reduce their reliance on opioids by about 40 milligrams morphine equivalent per day. But the evidence is only very low certainty. This is an observational study that came out just after we did our systematic review, and it confirmed this possibility. Here you have individuals at low, moderate, and high opioid use. You see that at this blue line, this is when part of the group was given access to therapeutic cannabis, and in all cases, they were able to reduce their use of opioids as compared to the group that wasn't given access. It's observational data, fairly strong signals. Again, you got, almost 50% reduction in opioid use amongst individuals that were given access to therapeutic cannabis versus the control group, which had much smaller reductions. We don't know if this is a causal effect, but it certainly seems to be interesting. So because of this, the panel made a conditional recommendation that for individuals living with chronic pain, currently using prescription opioids, and interested in reducing their opioid dose, the panel suggests offering a trial of cannabis for medical purposes as one possible approach to facilitate opioid tapering. It's not the only thing you could try. There are many other types of alternatives to pain management that might help, but cannabis might be one of them. Conditional recommendation, means shared decision-making. And again, we put in once again that even for individuals that agree, that are interested in a trial of opioid tapering, they have to have the option to pause or discontinue that trial based on how they respond. And again, once again, we make the point that involuntary tapering is not an evidence-based strategy. What about cannabis versus opioids to manage chronic non-cancer pain? Well, we conducted and published something called a network meta-analysis that looked at this issue. And interestingly enough, we found that the evidence suggests that opioids and cannabis appear to be similarly effective for pain, sleep, and function. They appear to be similarly ineffective for social functioning, role functioning, or mental functioning. And the opioids have the potential of greater harms. You can fatally overdose on opioids. You cannot fatally overdose on cannabis. Because of this, in the panel's final recommendation, they advised that if initial treatment, standard treatment for chronic pain proves insufficient, that patients should be offered a trial of cannabis for medical purposes before a trial of opioids. And again, it's a conditional recommendation and a mandate for shared decision-making. But if they're similarly effective and one has less potential for serious harms, it makes sense to at least try that first before moving to something that could be more harmful. So, in conclusion, neither opioids or cannabis for medical purposes are going to work for everybody with chronic pain, but they appear to have important benefits for a minority of patients. They should Non-opioid therapy and non-cannabis approaches should be optimized first for chronic pain, but for patients who do not achieve satisfactory results, it's reasonable to offer them a trial of cannabis and lastly a trial of opioids, unless patients have some important risk factors with respect to opioids. And that is, as far as we know, an active alcohol use disorder or a prior history of opioid overdose. That summarizes my presentation. I apologize if I went a little bit long there, trying to share a lot of information, and happy to hand off to the next speaker.
Thank you so much, Jason. Yeah, that it really is such a pleasure to get to hear all of the newest information and research so that we can feel informed about making the best decision when we want to look at these things and knowing that it's available for us and that there's so much work being done currently in order to make sure that people have these choices and have some autonomy in their decision making about what they're using. So, thank you again, Jason. My name is Desmond Williams. I'm here in Vancouver, BC, otherwise known as the stolen unceded territories of Musqueam, Tsleil-Waututh, and Squamish peoples. I'm somebody who is proud to be a part of the PTPT steering committee, so I've had a part in helping to organize this conference this week. I'm also the co-director for the Pepper Project, which is a research project in finding equitable ways to do research with people with chronic pain. I'm also part of the National Advisory Committee for Pain Canada, which is basically overseeing how we can approach pain to make Canadians' lives better. And I'm somebody who has also lived with pain for the majority of my life. The earliest memories of pain were when I was 7 years old, and I couldn't go to some tryouts for a track meet. Um, Even though at that point I was fully engaged in sports and physical activity, pain started to be a part of my everyday life and every game and practice that I was involved in. And my early part of my life, from 4 years old until I was about 24 years old, I played sports, and that was my main identity. That was how I, gained regard, respect, made connections with friends and community. And even though pain was a major aspect of it from an early point, part of what made me transition out of being an athlete was that I could no longer do it anymore. I retired from lacrosse at 16. I said it was because I'd had enough of it. I'd played for 12 years and won some championships and had some good times in it. And I was like, that's enough for me. But deep down inside, it was because every game, every practice, every aspect of what I was doing, from running to hitting and being hit, hurt. And at the end of every game, there was so much recovery that was required for me to get back into the game again that I ended up eventually quitting. And my high school sports career, which I had high hopes of maybe playing some post-secondary sports and pursuing post-secondary education, my last football game of my grade 12 season, I had the heaviest guy in the league fall on my foot. And for about 6 months, I was limping because nobody could figure out what was actually wrong with my foot. Um, which I'm very lucky that somebody figured that out at some point, a very talented physiotherapist. But that football season was also the first time that I was offered something to help with my pain in the realm of medicinal cannabis. So my first week of grade 12 was actually the first time I tried cannabis, which, I was still in high school. Many recommendations, many people have things against younger people using cannabis because of brain development. But at the time, one, I was already using non-steroidal anti-inflammatories, and I had had a number of brain injuries already at that point. And so there were already some things in motion. And when I first tried cannabis, it was actually the first time in my memories at that point that I wasn't worried about my pain at the end of my day. I was able to enjoy a social function with my friends where I didn't have to drink because I consumed cannabis, and I actually enjoyed the process. And it wasn't something where in the back of my mind I was just worried about all of the pain that I was feeling from our game earlier in that day. And I'm somebody who, over the years, before legalization, this was long before legalization, when I first tried cannabis, I did pursue the many different methods of ingestion. I did try edibles and tinctures and topicals and so many different things to try a well-rounded approach of how I could, try to manage my pain. And I'm somebody who still to this day uses many different methods of ingestion when it comes to cannabis because I find different days, different moments, different parts of my body, different things can be effective. And it's one of the things that in my years as an educator, working in the cannabis industry, I did take some time working in the medicinal field of cannabis again before legalization. And one of my main roles was helping people get uh, comfortable and feel confident about understanding the different roles of the different methods of ingestion and how they affect us. And so Jason mentioned how, with smoking, there are these pulmonary risk factors, but there's also the quick onset of pain relief that some people do recognize with smoking and vaporizing and other inhalation methods. And although there are many people who feel or maybe believe in the stigma that smoking is the non-medicinal and only the recreational way to consume cannabis, and other consumption methods are the medicinal. Like Jason had mentioned, there are some people who, based on either their belief systems or other things happening in their life, these other methods can be the best choice for them based on what they feel is best for them. And within those things, there are many different ways of accessing THC, CBD, CBG, CBN, all of this wide range of cannabinoids that actually have different effects on us when we consume them. And there is, some evidence and some research out there about those other cannabinoids, but unfortunately, due to prohibition, we are pretty behind as far as the research aspects go because we just weren't allowed to research the medical efficacy of cannabis until the legalization started in the medicinal field. And so when it comes to, my experience as a person with pain, I'm somebody who, again, was uh, dealing with pain at 7 years old, but I wasn't diagnosed until I was about 21. And when I was 21, at that point, I had been consuming extra strength ibuprofen and muscle relaxers and NyQuil at nighttime and all sorts of other things alongside my cannabis use in order to try to manage my pain. And once I did finally go to the doctor to talk about my pain, get into the rheumatologist and start the program of working through the pharmaceuticals, when I continued on with the pills, first with naproxen, my stomach decided that that was no longer a thing that worked for me. And so those types of anti-inflammatories started to, get moved out of my practice. And because of the progress of my particular condition, I have something called ankylosing spondylitis. And because I had been dealing with it for so long, the progress, um, it was getting pretty far along, and so they pushed me into the biologic immunosuppressants. And so I was actually on biologic immunosuppressants for 8 years, but again, I found that my body did not respond well, and I gave it a good go. It was 8 years. And I'm lucky to say that through the different methods of ingestion with cannabis, many different movement and energy practices that I did get the opportunity to pursue because of the space that I was offered in that time with biologics, to find times without as much pain. I was able to find a little bit more autonomy, a little bit more choice in how I was able to manage my pain with more natural processes, things that felt better with my body. And I recognized that not everybody's body responds well to cannabis therapy. And, everyone's endocannabinoid system is working at a different state of equilibrium and balance. And
Thank
so,
you,
I'm here
Desmond.
to,
Can we
yes,
move on
yes,
to, in the interest of time? I'm sorry,
yeah,
we would like to hear from Alex, and we have a ton of questions.
yeah. I
So,
was just about to
yes.
wrap up and hand it
Okay,
off to
thank
Alex
you.
there with
Thank
that last
you.
part.
Okay, finish up.
Oh, no, I was literally on my last words right when you started to speak. So
All right.
bringing it on to Alex.
Okay.
Perfect timing. Yeah, I'll try to keep it fairly brief as well. So, hi everyone, I'm Alex. I am joining from so-called Kingston, Ontario, which is the stolen land of the Haudenosaunee, Huron-Wendat, and Anishinaabe people. I am joining to represent the folks for whom opioids are in fact a good treatment option and who have also been systematically denied access to those. So I mentioned, or rather, Therese mentioned in her intro that it took me 26 years to get my first chronic pain diagnosis. And of course, now my dog's coming in. They've been quiet since 3:30, but part of the barrier that I've experienced to accessing effective pain care has been that no one is ever really willing to diagnose me. They'll say, your symptoms seem like X, Y, or Z. But I am one of those people who usually has negative test results. And even if the condition's something that could be diagnosed purely off of clinical symptoms, most of the doctors I've dealt with in my life are not actually willing to commit to saying I have the thing. They'll say your symptoms are similar to the thing, which does not get you the sort of authority of a diagnosis to then pursue causative treatment. So really what I am left with are symptomatic control and not control of the root cause. And I think that's a really important thing to keep in mind when we're talking about who has access to what effective pain care solutions. But even setting that aside, codeine and I want to say hydrocodone, the opioids that I've taken, which are codeine, morphine, and I believe hydrocodone, they are simply the medications that have worked best for me in terms of my pain. They are the ones that have controlled my pain best with by far the fewest side effects. I've tried so many other medications. I've tried gabapentin, which I actually quite liked from a mental health perspective. I did not experience the horrific brain fogginess and drunken feeling that a lot of people report. It just sort of helped with my baseline sort of autistic cognitive and sensory overload levels and with sleep. But unfortunately, it also made my pain worse, as has every strain of cannabis that I have ever tried, and I've tried quite a few of them. They actually, for some reason, the way that my nervous system works, they make my pain way, way worse. Triptans cause me to have muscle spasms, hypersomnolence. I'm also narcoleptic, and really debilitating brain fog. It's actually scary. Like I start losing words. They're very disconcerting. I still take them because, it's a harm reduction equation. And sometimes the migraine is worse than the brain fog and the muscle spasms. Ibuprofen is the only NSAID that I tolerate these days, and it takes the edge off just about enough to let me get out of bed in the morning, but not enough to actually bend over and put my shoes on. I tried Nabalone recently, and it caused me to experience derealization and depersonalization. On the other hand, when I had post-surgical opioids, I actually felt really energetic. There's a story that my mother used to tell, which was I was given, I believe, morphine after having a bone marrow biopsy around age 4. And she liked to say that I reacted really badly to morphine because all of a sudden I was like hyper, and she was worried I was going to run out into traffic. And in hindsight, as an adult who then got hydrocodone after another surgery, I realized that what she was seeing was the only time that she'd ever seen me as a child not in pain. She saw me acting like a normal child and not one who was in constant sensory overload because I was autistic and dealing with unmanaged pain. That was why I was hyper to her. And I experienced similarly, I was so energetic despite the fact I just had surgery after I had my appendix out because I was given hydrocodone for a few days. And I felt better post-surgery than I ever usually do. And I think one of the things, I don't want to sort of go on too long, but I think the couple things that I want to highlight are I have been prescribed other medications that I've had really horrific reactions to. And when I've talked about those horrific reactions, I have not been believed about how they were affecting me. Because again, those were unusual reactions because I tend to react to medications in an unusual way. I was prescribed modafinil for my narcolepsy, which made me hypomanic and caused, again, debilitating muscle spasms. I get those a lot for some reason, and a paradoxical increase in one of the symptoms of narcolepsy, which is cataplexy. And I talked to a few doctors about this, and every one of them told me that modafinil is not reported in the literature to cause any of these things, with the implication that I was just attention seeking and complaining for no reason. Meanwhile, about a third of the people in my online support group were experiencing the same kinds of side effects. So I've been told I'm drug seeking and attention seeking quite explicitly by some doctors. I've been told very recently that I just need cognitive behavioral therapy to learn to cope better with my pain, that I just need to exercise. And, it's hard, but you need to push through the pain. And what they're not recognizing is that I spend literally all my time pushing through my pain. That's not the problem that I have. It's that pushing through the pain is exhausting. And that when you're trying to work full time to survive in our society and do your laundry and clean your apartment so it doesn't set off your mast cell syndrome, you don't have the time or the energy to exercise regularly unless someone gives you medication to control your baseline pain. So I think one of the things that is really highlighted for me by the new opioids and cannabinoids guidelines is that we have a real problem with shared decision making in our healthcare system, and that I think the next step to actually ensuring people have access to effective pain management is developing strategies to ensure that people actually have access to real shared decision making and examining the scope of the problem that we do not have that. Because the problem is that when I try and raise these issues to my doctors, I'm called drug seeking. I'm told that the fact that I use over-the-counter codeine is the reason I have pain in the first place, even though it very obviously is not if you actually look at the pattern of my symptoms. So I think like that's sort of the one message I'd like to sort of advocate from my service or strategic design perspective is, now that we have these evidence-based guidelines, how do we actually move forwards to ensuring that doctors are taking them on and implementing them, and not just operating on really, really harmful biases?
Thank you, Alex. So that was aimed at you, I think, Jason. Do we have time for questions?
I'm certainly happy to answer if I can. I've been sort of typing in
Yeah.
the chat window there, but it's a great question. So how do you ensure that there's sort of appropriate dissemination of the guidelines to encourage that practice reflects what we think the evidence suggests is quite appropriate? It is a challenge. We're trying to undertake that quite a bit, but the reality is you've got competing guidelines out there, right? So you have the new UK NICE guidelines for chronic primary pain that have made strong recommendations against opioids at all. The new Department of Defense U.S. Veterans Affairs guidelines, strong recommendations against opioids for chronic pain, full stop. I think there are problems with those guidelines. I think that they have failed to take into consideration patient values and preferences. They have instead used the values and preferences of the clinicians and the guideline developers, and they are much more risk adverse. They tend to place a lower value on the possibility of pain relief. They're much more focused on the harm reduction aspect. I don't think that reflects what we have learned about patient values and preferences. So it's going to be an educational campaign. It's going to be a matter of getting the material out there. It's going to be a matter of getting clinicians to understand, why does one guideline say that opioids are a reasonable option if other things have not worked, whereas other guidelines are making different recommendations. Certainly at the National Pain Center, we are committed to undertaking that. We have a project underway led by one of my colleagues, Andrea Darzi, called the E-Chronic Pain Rec Map, where we are trying to put together competing guidelines on the same topic. We're particularly looking at guidelines on opioids and cannabis to help clinicians and patients understand Why are there differences in the recommendations when they're all looking at the same evidence and they're all trying to address the same question? And it's differences in terms of how that evidence is synthesized, and it's differences in terms of how patient values and preferences are considered. So I hope that we can have some success in that space. We're quite keen to try.
That answered quite a few of the questions that had come in. People had asked about what are the guidelines in the UK and the US. One question I would like to ask Desmond is, what if any challenges have you experienced in traveling to the States and countries where marijuana is not legal?
You know, there have been times, those are some of the few times that I have had access. But, you know, speaking in a public forum, there are also certain ways, to get things where you need to go. You know, when I was working in the medical cannabis space, there are many people who use capsules and they just put it in their pill bottle. With their other medications, those types of things. You know, I'm not encouraging people to try to smuggle things over borders, and there's much risk to that.
Yeah.
But there's not always safe access in other spaces, and if that is your primary, you know, thing that you use for pain management, it is something that, again, we're finding the risk management offsetting here, and yeah, it's one of those things where you might have to make decisions, like maybe just a topical or something like that, and take the label off, and you know, call it a day. But that's as deep as I'll get into it. But
Thank you.
yeah.
Okay. Well, thank you,
Uh,
everyone. We have run out of time, and it's a very interesting subject, to say the least. And we could talk for another hour, I'm sure, quite easily. But thank you all for your great takes on this subject. Over to
So
you,
much.
Alvin.
Any questions or anything I can provide, please send an email. Happy to send papers, happy to address anything we couldn't get to during the presentation. Thanks so much.
Awesome. Thank you so much to our panelists for this important session. And thank you to all of you for joining us for one or more sessions on day 4 of our conference.